Good morning. It is a great honor for me to be joining you to talk about pancreatic neuroendocrine tumors in patients with tuberous sclerosis. I'm Cristina Ferrone. I am a surgeon at the Massachusetts General Hospital who specializes in pancreatic neuroendocrine tumors. We know that there are many different multi-system effects of tuberous sclerosis, including in the pancreas. In the pancreas, patients develop all types of different lesions. They can develop benign lesions or potentially malignant lesions. But one that we are seeing much more often in tuberous sclerosis patients than in the general population are pancreatic neuroendocrine tumors. Now, pancreatic neuroendocrine tumors come in two varieties. They can be functional, where they secrete a hormone and the patients have symptoms, and these symptoms are due to the abnormal hormonal production. From the patients that we've seen, most of the patients have all had non-functional pancreatic neuroendocrine tumors that don't produce any hormones, and they're usually found during routine surveillance. And so you can see from this graph that the majority of the pancreatic neuroendocrine tumors and what we know about these tumors has really been gained from the general population, because TS is very rare, and then having a neuroendocrine tumor in TS is still a small subpopulation of the patients. It's just at a higher rate than the general population. And so what we do when we find these pancreatic lesions, we usually do what's called an endoscopic ultrasound, where an ultrasound probe is put through the mouth, down the esophagus into the stomach. The pancreas is ultrasounded, and a needle is utilized to do a biopsy of the lesion. And that can tell us, is it a cystic lesion or is it a solid lesion? And is this a neuroendocrine tumor? And then usually we are able to get even more information about that neuroendocrine tumor in terms of how fast the cells are turning over and potentially how aggressive the neuroendocrine tumor could be. And so we know from the data that we have from the general population that patients who have low-grade neuroendocrine tumors that are less than 2 centimeters in size, we usually recommend observation. If the lesions are growing fairly quickly or are larger than 2 centimeters in size, or on the biopsy have evidence of faster cell turnover, which might mean that they might be more aggressive, we then operate on these patients earlier. The type of operation obviously depends on where this lesion is in the pancreas. So if it's in the body, in the tail of the pancreas, we do what's called a distal pancreatectomy, where we divide the pancreas and often take the spleen. If the lesion is in the head of the pancreas, we do the operation called the Whipple operation, which is far more extensive, involving the removal of the head of the pancreas, the duodenum, the common bile duct, and the gallbladder, and oftentimes part of the stomach. And as you can imagine, that's a much more significant operation. So from 2006 to 2021, Elizabeth Teal and I have been working together, and which has really been a wonderful collaboration. I'm thankful to the Herscott Center and all of the members of her team for including me in taking care of these wonderful patients. 637 patients were diagnosed with TS, and 28 patients had some type of pancreatic lesion identified. 15 patients had a pancreatic neuroendocrine tumor confirmed on pathologic biopsy, either through removal of the lesion or through biopsy of the lesion. And while this is not a large group of patients, when you think about the general population, it is a large group of patients with TS and neuroendocrine tumors. And so we take care of a lot of patients from the general public with neuroendocrine tumors, and we compared patients from the general public to those with TS, all who've had neuroendocrine tumors. And those patients who have TS tend to be younger than the general public who has a neuroendocrine tumor. Thankfully, many of them are identified when the lesions are still fairly small, and so we're able to do minimally invasive operations, which is better for the recovery of the patient, especially when we're talking about operating on children. However, what we've also learned is that oftentimes the neuroendocrine tumors are actually multifocal in the patients who have TS, whereas when we look at the general public, the lesions tend to be solitary rather than multifocal. Thankfully, the postoperative complications were no different between the two populations, and only one patient had, what we were debating was a recurrence versus a new primary about 34 months after we operated on them. Most likely, this is a new lesion and not a recurrence. And there were absolutely no deaths related to the neuroendocrine tumors in the patients with tuberous sclerosis. And so currently, we really lack guidelines for the surveillance of patients with neuroendocrine tumors and tuberous sclerosis, and we have a lot to learn. We do know when neuroendocrine tumors become more aggressive, we can consider treating them with an mTOR inhibitor. And so if the TS patients are on mTOR inhibitors for other reasons, this may affect and slow down the growth of the neuroendocrine tumors if they have any or are predisposed to have any. And so we need to figure all of this out. And it really is through the cooperation of all the families and patients with TS that we are learning more and more, and hopefully can try to avoid operating on patients too early if they have a neuroendocrine tumor. And so in conclusion, hopefully the take-home messages that you have from this talk is that while TS patients are presenting at a younger age with neuroendocrine tumors, it doesn't seem like this is affecting their overall survival. Oftentimes, these lesions are multifocal, and therefore we will need to continue to follow TS patients and monitor their pancreas over time. They have a very favorable prognosis, and as we learn more, we will be able to refine our guidelines as to when to operate on these patients so that we don't operate too early. I really want to say a very big thank you to all of the TS patients and their families who play such an important role. The leadership of Dr. Teal and the members of the Herscott Center that has allowed us to really bring all of these clinicians together to try to optimize the care of the TS patients and allow us to develop really unique multidisciplinary teams here at MGH. Thank you very much for your attention.